بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا أكرم الأكرمين. Dear colleagues, this is one of the major topics in head and neck imaging concerning evaluation or imaging of the orbit. And because this is a relatively long talk, I have divided it into two parts. In the first part, I will deal with the globe and the optic nerve, and in the second part, I will handle the rest of the anatomic and pathologic details. In order to examine the orbit by CT or by MRI, we should have the axial and the coronal planes. In the axial image, we usually start parallel to the orbital floor and then continue until we reach the region of the frontal sinus. In the coronal plane, we usually start near the orbital apex, perpendicular to the orbital floor, and proceed anteriorly until we also finish the region of the frontal sinus. The scanning intervals are usually taken at 3 millimeter. When we select a suitable field of view to cover the area of the orbits and the adjacent structures, we should ensure symmetric patient position on the machine. And in imaging display, we use the bone and soft tissue windows, and sometimes we need to inject intravenous contrast material. The orbital anatomy is simple since there are a few important anatomic structures within the orbit. The most important is the globe, of course, and the extraocular muscles, as well as the optic nerve and the lacrimal gland. You know that the extraocular muscles, we have the lateral rectus, the medial rectus, and the superior rectus, which usually blends with this levator palpebrae superioris muscle. They are both are seen as one bulk in the imaging. In the inferior rectus, and sometimes we can see the inferior oblique, but it's difficult to see we can see the superior oblique, and we cannot usually see the inferior oblique muscle. These are axial CT scans of the orbit, starting from below and going upward. And first you will see the inferior rectus muscle in the midline, and while proceeding up, you see in the midline or in the mid plane of the orbit, you see the optic nerve, and this is the medial rectus, and this is the lateral rectus, and you can also see the globe. And here you can see the globe and the lateral rectus, as well as the medial rectus. Then this is the globe, optic nerve, the medial and the lateral recti. While you are going up, you will see the superior rectus levator complex in the upper sections. Then in the coronal images, you are able to see all the muscles, and this is the inferior rectus, the lateral rectus, the medial rectus, the superior rectus levator complex, and this is the optic nerve. Then while you go from posterior to anterior, and then you will meet the globe, and also you will see the lacrimal gland. By MRI, we have almost the same technique, and we have the slice thickness about 3 millimeter. We use the axial and the coronal plane. Sometimes we have the sagittal images for the diseased orbit. Then we should have the T1 and T2 weighted images, and sometimes we need to have the fat suppressed images as well. This is the inferior section. You can see the inferior rectus muscle, and here is the optic nerve, lateral rectus, medial rectus, and this is the globe. And you proceed upward until you meet the superior rectus levator complex, and this is one of the important veins in the orbit, which is the superior orbit ophthalmic vein. And in the coronal planes, you have the same anatomy. This is the lateral rectus, medial rectus, inferior rectus, superior rectus levator complex, and this is the superior oblique muscle on the corner of the orbit. Then, as I have said, you may need to have the fat suppression techniques before and after injection of contrast medium. Here is after injection of contrast, you have suppressed the orbital fat so that you can see if any orbital pathology that can be better delineated on the background of black fat. And this is the lateral rectus, the medial rectus, and you can nicely see the superior ophthalmic vein, and here you can appreciate the right lacrimal gland, and this is the normal left lacrimal gland. Then this is the axial T1 weighted image before fat suppression, and this is after fat suppression. Both are performed after intravenous contrast injection. And this is just an example to demonstrate the value of fat suppressed images. This is in orbital hemangioma, one of the common lesions seen in adults, and the hemangioma is black in the T1, and whenever you give contrast, the hemangioma will enhance and it will become bright, so that the delineation or the difference between hemangioma and fat will be less. Then if you have the fat suppressed technique, you are able to see the hemangioma more better. And here you can see the superior ophthalmic vein, which is one of the anatomic landmarks used for assessment of different pathologies related to the orbit. And this is the coronal image, where you can see the superior rectus levator complex, the superior oblique, medial rectus, inferior rectus, and the lateral rectus muscle. And then once more, here you see the superior oblique, the medial rectus, inferior rectus, lateral rectus, superior rectus levator complex. Then one of the best ways, in my opinion, to handle the orbital pathology is to locate the different pathologic entities to a certain anatomic area. And we have 5 or 6 anatomic areas in the orbit. The first and the most important area is the region of the globe, then the optic nerve, then the lacrimal gland, then the extraocular muscles, then the intraorbital fat, and finally the orbital bones. Starting by ocular lesions, meaning that the lesions that occur inside the globe. And we have important lesions, and then we'll discuss some of the other lesions that can be seen also within the globe. We have the retinoblastoma, melanoma, metastatic deposits, and a few other lesions. Then retinoblastoma is of course a disease of the childhood, and it usually presents in the first 2 years of life. And commonly the patient presents by white eye or leukocoria, and here you can see that the pupil is white instead of being black. Then if you see a mass inside the globe in a child, then you think of a retinoblastoma. Then this retinoblastoma is relatively a hyperdense lesion. It shows calcium in most of the cases, and if you inject the contrast media, you can see some enhancement. And you should remember that retinoblastoma is a bilateral disease in about 30% of the cases. And here you see bilateral retinoblastoma, intraocular mass on the left side, and multiple foci of calcification and masses within the right globe, representing bilateral retinoblastoma. Then retinoblastoma by MRI will appear of intermediate signal in the T1 and also in the T2 weighted image. And if you inject contrast, it will show similar enhancement to the CT, meaning that the enhancement will be faint. Then if you see a retinoblastoma in one of the globes, you should look carefully for the opposite globe in the axial and in the coronal planes, looking for a bilateral disease. and this is very important and is diagnosed by the presence of a polyp or a mass inside the globe that in most of the cases shows calcification. And this is a case of retinoblastoma. On the right side there is a mass, and you cannot appreciate very much the presence of calcium, but the left globe is intact with no evidence of bilaterality. Then what you should look for if you are going to diagnose retinoblastoma? Number one, you should see calcium, which is better detected by CT, of course, compared to the sensitivity of MRI, which is not sensitive. Then you should look for bilaterality. Then you assess extraocular extension, because this tumor may extend along the optic nerve into the intracranial area, affecting also the suprasellar area. And then this is an example: a female child 2 years old with exophthalmos. Then you see big mass inside the left globe showing dense calcium, and then the mass has extended outside the confinement of the globe along the course of the optic nerve, and in the intracranially you can see a faintly enhanced lesion in the suprasellar area representing intracranial extension. And retinoblastoma by MRI will appear of intermediate signal in the T1 and also of intermediate signal in the T2 with faint post-contrast enhancement. And this is also a retinoblastoma by MRI coronal T1 weighted image, and this is an axial T2 weighted image. There are bilateral disease being larger on the left side and smaller on the right side. Then this is a retinoblastoma in the right globe by T1 sagittal, T2 axial, and the axial T1 after contrast injection, before fat suppression and after fat suppression. Actually, the value of the fat suppression techniques are not so much for evaluation of ocular lesions, especially if the lesion is confined to the globe. Then the lesion shows intermediate signal in the T1 and also intermediate signal in the T2 with homogeneous contrast enhancement. Then this will lead us to look at other lesions that may mimic the retinoblastoma, and they are known in the literature as pseudo-retinoblastoma. There are three major lesions which can occur in the globe of the pediatric patients, may simulate retinoblastoma, and they are not. The first one is persistent hyperplastic primary vitreous. The second one is Coats disease. The third one is known as retrolental fibroplasia or retinopathy of prematurity. In these all three conditions, you got white globe by CT and by MRI, and there is no calcium, and this is a very important differentiating point. Then the density of the vitreous will increase on CT, and also it will increase on MRI, showing high signal, and you cannot detect calcium, of course, in these lesions. The first one is known as primitive hyperplastic or persistent hyperplastic primary vitreous, which is a congenital persistence of remnants of the hyaloid vessels. In this disease, the globe is usually small, and the lens is appreciably distorted and may be replaced by some fatty tissue. Then if you look to the manifestations of this disease, the hyperplastic primary vitreous, and you can see the globe is small, the globe is white, the lens is distorted compared to the normal appearance, and there is no calcium inside the globe. This is a congenital disease. Then you got irregular of the lens, irregularity of the lens, shallow anterior chamber, and a generalized increase of the vitreous density, intravitreal shadows, and maybe fluid levels secondary to subretinal hemorrhage. And this is by MRI T1 weighted image. This is the normal globe, and the affected globe is small. The lens is relatively abnormal, and you got some shadows posterior to the lens, and you also see this vertical line which represents a retinal detachment, and the fluid levels, meaning that there is some hemorrhage inside the globe. This is also persistent hyperplastic primary vitreous. The globe is small and the lens is distorted, and then there is increased density without the presence of calcium. Another example by MRI, you see the left globe is small, the left globe is bright in the T1 and in all images, and you may got some abnormalities in the lens as well. Then you keep to the Coats disease, which is a unilateral disease, and it's not a congenital lesion, but it usually seen in boys at the age of 6 to 8 years. Similar to the rest of the three other entities, the two other entities, the globe is increased in density and also in signal by MRI, but the globe is of normal size and the lens is usually normal. Then in cases of Coats disease, you got normal size and shape of the globe, normal lens morphology compared to the opposite one, and no retrolental masses or retrolental shadows. And this is a case of Coats disease in a male 70 years old. And you see the globe is bright in the T1 and in the T2 and T1 post contrast. You see some shadows inside the globe represents detached retina. And if you have the chance to see the lens, and the lens is almost normal compared to the opposite one. The third lesion of retinoblastoma mimics is retinopathy of prematurity, and this disease is seen in premature infants who are receiving oxygen therapy. This will result in fibroblastic overgrowth of the persistent vascular sheet behind the lens, and this is will appear like this. You see an abnormal soft tissue density posterior to the lens, hence the name retrolental fibroplasia. And this disease is bilateral, and the globe are usually small. Posterior to the lens, you see a shadow which is dark in all pulse sequences because of the presence of fibrosis, and the globes, of course, will show high signal as similar to the two other lesions. Then retinopathy of prematurity is a bilateral disease, while Coats disease is unilateral, and also the persistent hyperplastic primary vitreous is usually a unilateral pathology. In persistent hyperplastic primary vitreous, the globe is small with distorted lens and retrolental shadows. But this can be easily differentiated from retinopathy of prematurity because of the history of premature and oxygen therapy, and because of the bilaterality as well. Then Drusen disease is just calcium which is located at the region of the optic disc. This can be unilateral, but commonly can be seen bilateral. This is known as Drusen disease. Staphyloma is an abnormality in the configuration of the globe, and you see here this globe is not an exact ball like the right one, but you see some deformity in the posterior coat of the globe, which is known as staphyloma. Coloboma is a defect in the ocular coats leading to the formation of a retroocular cystic lesion communicating with the ocular cavity and containing some of the vitreous. Then the globe will be small because of some of its contents are now in a cyst behind. Coloboma can be large and can be small, like this one and this is also a case of coloboma by MRI on the right side. You see the globe, there is a big defect in the ocular coats, and there is a cyst retroocular that is connected to the globe itself, and this is coloboma. Coloboma can be unilateral and can be bilateral, like this one. This is the globe and this is the cyst behind the globe on both sides. Then if you see an intraocular mass and this mass is, in this patient is an adult patient, then you think of the possibility of malignant melanoma. And malignant melanoma is an intraocular mass that may also extend outside the globe in about 15% of the cases. Then whenever you see a mass inside the globe in an adult, you think of a malignant melanoma. This mass may be hyperdense in the pre-contrast study on CT and shows moderate enhancement. It does not contain calcium. Malignant melanoma will show intermediate signal in the T1 and T2 and show moderate enhancement also by MRI, as you can see here. Then if the melanoma is containing melanin, it will appear of high signal in the T1 and low signal in the T2. But if it is not containing melanin, in cases of amelanotic melanoma, then the lesion will show intermediate signal in both T1 and T2. But in both conditions, the lesion will show some enhancement after contrast injection. And this is a malignant melanoma with brain deposits. The lesion is of intermediate signal in the T1 weighted image, and in the T2 weighted image there is hemorrhage inside the globe with retinal detachment, and there are hemorrhagic deposits in the occipital lobe on the left side. Then malignant melanoma will appear by ultrasound, and this is one of the advantages of ultrasound over CT, especially when there is associated vitreous hemorrhage. The ultrasound can see the lesion more better against the vitreous and can assess the vascularity of the lesion by the Doppler, and MRI is good if there is hemorrhage because of the clear difference between the signal intensity of the lesion and the hemorrhage inside the globe. Then this is the melanoma, and both contrast sagittal and axial T1 weighted images showing an intensely enhancing mass inside the anterosuperior aspect of the right globe. Then one of the lesions that occur both in children and in adults, and this is a benign lesion known as the choroidal hemangioma. You know that the hemangioma is a hypervascular lesion. It will appear of high signal in the T2 weighted images and may show a strong enhancement after injection of contrast. In the literature, they say that if you see the lesion intimately related to the region of the macula or the attachment of the optic disc to the globe, then this may favor the diagnosis of hemangioma. And if you look here, this is the choroidal hemangioma in a child. The lesion before contrast injection looks like this, and after injection of contrast it shows intense homogeneous contrast enhancement. This is the choroidal hemangioma, is a congenital vascular lesion, usually manifest in the middle age or elderly people, but can be seen also in the pediatric age group. As I have said, this is a benign lesion confined to the choroid, and it shows a smoothly elevated dome-shaped choroidal mass with intense post-contrast enhancement. Then look here and you see this is the choroidal hemangioma before contrast in the T1 and in the T2 weighted image, and after contrast injection showing intense strong enhancement. Then one of the differentiating points between choroidal hemangioma and melanoma, if they are seen in an adult patient, is the appearance of the lesion in the T2 weighted image. Because hemangioma is very bright in the T2, you cannot see the lesion against the vitreous in many cases, but the melanoma will appear of intermediate signal compared to the brightness of the vitreous in the T2 weighted image. And if you see lines going through the globe, you know that these are detached retina, which may be associated with hemorrhage like this, or may not be associated with hemorrhage like this one. Then this is hemorrhagic retinal detachment. You see the line, and you see hyperdense vitreous due to hemorrhage. And this is an MRI of a different patient showing hemorrhage and the line of retinal detachment. And metastasis can occur in any region of the orbit, like metastasis occurring anywhere in the cellular area. Metastasis can occur in the globe, can occur in the optic nerve, can occur in the muscles, can occur in the lacrimal gland, and can affect the bony orbits, of course. One of the common lesions presenting by intraocular deposits is the breast cancer, also the bronchogenic carcinoma, and the kidney. All these three primaries have the highest incidence to produce intraocular malignancy, intraocular metastasis. Then if you see a lesion inside the globe in an adult, you should think of the diagnosis of melanoma, as happened to this male patient with sudden onset of severe pain in the left eye and radiologically suspected to have melanoma and required emergency inoculation. After surgery, the lesion was proved to be metastatic from lung cancer. Then commonly, if you don't know that the patient had a primary malignancy, you diagnose this lesion as malignant melanoma. But if you know that the patient had a primary malignancy, then you should combine both lesions to a single pathology, and you think of metastasis from the non-primary malignancy. The orbital trauma will be handled in full details in the section of maxillofacial injuries, but here something about the globe which has been ruptured, and these are the signs of globe rupture. I will mention once more in the imaging of maxillofacial trauma. The flat tire appearance of the globe, thickening of the posterior sclera, hazy inner scleral margin, and of course intraocular air. All these are the signs of globe rupture compared to the intact globe on the left side. Then trauma may cause lens displacement or dislocation, and here is an example, and you see some displacement of the lens and periorbital edema and contusion. Then we came to the region of the optic nerve, and in the nerve we have meningioma, and we have glioma, and we have metastasis as well, and some other lesions. Then, and to start with, how to diagnose an optic nerve pathology. If you see a lesion like this, which is almost encasing the optic nerve, going along the course of the optic nerve, and this is an optic nerve lesion. But if you see a lesion like this, also masking the optic nerve fibers and also have the same direction of the optic nerve, consider it as optic nerve pathology. But if you see a lesion that is partly in contact with the optic nerve, this is not an optic nerve pathology. The optic nerve lesion will have the same course, will extend along the course of the nerve, whether you can see the nerve itself or you cannot see the nerve within the tumor. Then the most common two lesions here are the meningioma, and the meningioma, as you know, arise from the meningeal sheath of the optic nerve. Or it may arise from the orbital periosteum. It may extend through the optic nerve canal into the suprasellar area. The meningioma in the orbit represents about 5% of the primary orbital tumors. And as similar to any other meningiomas, they are seen particularly in females in this age group. One of the important signs for the diagnosis of optic nerve meningioma is what is known as the radiolucent tract sign. You can see the optic nerve itself within the enhancing tumor mass, meaning that the tumor is arising from the optic nerve sheath, not from the optic nerve fibers. And this is the lucent tract sign, which is diagnostic, one of the helpful diagnostic signs of a meningioma. Homogeneous post-contrast enhancement, it may show calcium, tubular enlargement of the optic nerve, may stop at the optic nerve canal or may go inside the intracranium. Then the bones adjacent to the lesion will show hyperostosis or calcification. These are two different examples of optic nerve meningioma. You see the radiolucent tract sign or on the right side, and this is also an optic nerve meningioma occurring near the orbital apex, and you can easily appreciate the optic nerve fibers within the tumor. Then this is an optic nerve meningioma. You can differentiate the optic nerve from its sheath by MRI, of course, and MRI cannot see calcium. CT is more better here, and both CT and MRI can show the hyperostosis resulting from the lesion. And this is a good example of optic nerve meningioma. You see the optic nerve fibers through the mass itself, and here also you see a lesion at the orbital apex, and you can see the optic nerve fibers going through the tumor mass. Then these are two different cases of optic nerve meningiomas, a big one on the right side and a smaller one in another patient also in the right side. In both cases you can see the optic nerve fibers going through the mass itself. In the glioma, which is the second lesion affecting the optic nerve, usually of the low-grade pilocytic type, and 90% of the cases are seen before the age of 20, meaning that this is a lesion of the pediatric age group, and in about 25% of cases the lesion is bilateral and is associated with neurofibromatosis type 1. One of the most important signs is that you cannot identify the fibers of the optic nerve within the tumor mass. And the second one is the tortuosity or kinking appearance of the optic nerve. And this is a CT of right-sided optic nerve glioma, and this is an MRI of left-sided optic nerve glioma. You cannot identify the fibers of the optic nerve within the tumor mass, and also you see the evident tortuosity of the nerve. The tortuosity of the nerve is also appreciated in this sagittal image, and here you see the homogeneous post-contrast enhancement. Bilateral optic nerve glioma is, as I have mentioned, can be seen in about 25% of cases and is related to the neurofibromatosis type 1, and you see an extensive lesion on the left side and a relatively smaller lesion on the right side. And this is a bilateral optic nerve glioma. By CT you see the appearance, tortuosity, and by MRI low signal in the T1, and this is the T1 post contrast after fat suppression. You can appreciate the strong homogeneous enhancement of the lesions on both sides. This is the difference between glioma and meningioma. In meningioma, you can see the fibers of the optic nerve through the tumor, while in glioma you cannot see. But please note that this is not a fixed rule, and sometimes you are not able to appreciate the fibers of the optic nerve within the meningioma. Then you go to the clinical findings, and also you see the age of the patient and the other manifestations. Optic neuritis is one of the lesions that can be seen frequently in patients with multiple sclerosis, and may be one of the leading presentations to investigate the patient for the possibility of MS. And you can appreciate the diagnosis of optic neuritis by having an MRI T1 weighted image after contrast injection with fat suppression. And here this is the normal appearance of the optic nerve, but here you can see that the optic nerve is not enlarged, but it shows homogeneous enhancement. Then one of the incidental findings, and they may be considered as normal variant, is the dilatation of the meningeal sheath around the optic nerve, what we call ectatic optic nerve sheath, and this is one of the good examples. In the coronal image you can see the optic nerve surrounded by a lot of fluid. There are usually minimal amount of fluid around the optic nerve. And thank you, alhamdulillah rabbil alameen, and continue in the second part inshallah.